Hello, this is Jerry Weinhouse, and I'm one of the pulmonary and critical care attendings at Brigham and Women's Hospital. And it's my pleasure to speak with you on sedation and delirium in the intensive care unit. I have no disclosures relevant to this talk. So, delirium is a syndrome. It's not a disease. A syndrome is an aggregate of signs and symptoms that are associated with a morbid process, together which constitutes a picture of disease. And the hallmark features of it are a disturbance in consciousness, change in cognition, and a disturbance that develops over hours to days and fluctuates in severity. And it's for that reason it can be easily distinguished from more chronic, long-standing problems, dementia, depression, and so forth. It's important that an assessment tool be used in order to establish the diagnosis of delirium. And on this slide, I'm showing one of them, but I want to make it clear that I'm not necessarily recommending any assessment tool over the other. This is the delirium assessment tool known as the confusion assessment method for the ICU, which was one of the first that was validated for use in the ICU, and specifically for patients who are mechanically ventilated. But there are others, and I'm not necessarily advocating for it, but it does point out the key features and how they've incorporated into this tool. And you can see that in the features 1 and 2 here are essential features of delirium. In other words, in order to have that diagnosis, you have to have an acute onset of change or fluctuation in the course of mental status that occurs within just a few days, and inattention. Without those two features, you cannot call what you're observing to be delirium. And then you have to have one of the other two features of either disorganized thinking or an altered level of consciousness. Lacking one of those features, you can call it potentially something known as subsyndromal delirium. But for the purposes of this talk, we'll just talk about the more established diagnosis with all of its associated features. And one of the problems with delirium is that it's often invisible. There are 3 types of delirium, and the most common type is the hypoactive form. It's the form where patients may appear to be quiet or reserved. Possibly you might think that they're depressed. They're not really causing trouble or attracting attention necessarily. But if you apply the assessment tool, you will find that they have an altered consciousness and altered cognition. And so it's for that reason that it's important to apply the assessment tool, because really just looking from across the room is not necessarily adequate for most patients. Most delirium is of the hypoactive subtype, although some will have both features of hyper and hypoactive delirium. It's the hyperactive delirium that appears most like somebody who's withdrawing from alcohol, for example, but that pure hyperactive delirium is actually quite rare. Old age is a strong predictor of the hypoactive form, as well as any form of delirium, really. It's one of the higher risk factors. And it's also important to note that this is something that occurs usually after the first day of being in the ICU. Usually around day 2 is when we start to see it, after the critical illness has begun. It's very highly associated with certain features of patients in the ICU, mechanical ventilation being one of them, with 60 to 80% of mechanically ventilated patients developing it. And again, if you systematically apply the assessment tool, then you find these very high numbers. They're surprising, but most of the time physicians are still not applying the assessment tool, so it may not appear to be that common, but I hope to show you some data to make that point. And it is very common still in patients in the ICU, but of lower severity of illness. So 20 to 50% of patients who have a lower severity of illness will still have an episode of delirium during their time in the ICU. This was a point prevalence study that was done and published in 2010 that involved 104 ICUs across 3 continents. And what they found was that on that day, November 27, 2009, of the 200 plus patients that they assessed, 32% of them were delirious at that moment in time. So it just gives you sort of a cross-section across several continents to again confirm that this is a large minority of patients in the ICU that at any given time will be diagnosed with delirium if it's looked for. And there are very important consequences of having any episode of delirium. Cost obviously is going to be higher for reasons we'll discuss. We're talking about thousands of dollars added to any individual's hospital cost related to the longer lengths of stay, longer time on mechanical ventilation, and so forth. And this translates into many billions of dollars per year associated with the additional cost of caring for somebody with delirium. In this graph, you can see that the cost is associated with the severity of delirium, which is often measured in terms of the duration of it. So mild delirium may be somebody who just has it for a couple of days, whereas a more moderate or severe course of it is measured in days or potentially weeks. And needless to say, but certainly highlighted in this graph, the more severe or the longer the duration of delirium, certainly the higher the costs that are associated with it. Why is it such a common problem in the ICU? I think at least part of the answer is that we're more and more taking care of patients who are older and sicker. And if you look at predisposing factors, these are things that patients bring with them to the hospital even before they become ill. Advanced age, dementia, and high medical comorbidity are among the most common risk factors, or I should say predisposing factors. And these are things that are more and more common to see in the ICU over time as patients are getting older and bring with them more comorbidities. The other predisposing factors, things like functional impairment, a history of alcohol use, so that's important. Patients who are actively drinking may be more likely to withdraw from alcohol. Patients who stop drinking alcohol are at higher risk for developing non-alcohol related forms of ICU delirium. And male gender and sensory impairment also are predisposing factors. If you look at the graphs, you can see that beginning really at about the age of 50 or 60, the incidence of delirium precipitously increases with each passing year of age. And similarly, higher Apache scores right from the beginning, the higher the Apache score, you are much more likely to develop delirium while in the hospital. There's a very direct and linear correlation between severity of illness and age, especially over the age of 65 to 70, and the likelihood that the patient will go on to develop a confirmed episode of delirium. Similar to the idea of medical comorbidities as frailty, and this is something that's been more recently looked at and gained some attention in the literature, is that the more frail the patient, I think this is intuitive, the more frail the person, the more likely they are to become delirious as well. And this graph shows some of the different frailty scores and the likelihood for developing, in this case, postoperative delirium. Needless to say, the higher the frailty score, the higher the likelihood of developing delirium. On the left side of this slide, I've simply included the 35 elements of the frailty index score, which is just one of these. That's the one that's shown here on the far right. It's a 35-element risk factor score, some of these elements are really quite pedestrian, things like inability to bank, inability to clean or cook, and then some of them are more medically oriented, diagnosis related. But if you add them up and then divide by 35, you come up with a score. And in this case, if you have a score that's greater than or equal to 0.3, which would be about 11 or 12 of the elements on this scale, then your odds ratio for developing postoperative delirium exceed 3. And so it's not hard to see how a person, especially an older person, could accumulate many of these risk factors for frailty, and that their risk for developing delirium would be quite considerable. So those are some of the predisposing factors, and then there are all the risk factors. These are the things that happen to them in the hospital and include things like bed rest and immobility, restraints, catheters, fluid and electrolyte disturbances, things that often are what we do to patients as part of our care. And these aren't necessarily things that cause delirium, but they certainly have an association with delirium. Now, I've highlighted medications on this slide because medications are one of those variables that we apply that, number one, has been associated with delirium, and number two, is an area that has gained a lot of attention as potentially where we can prevent delirium. A more thoughtful use of medications is certainly something that's become very much a part of how we manage patients in the ICU for this very reason. So there are many medications that have been associated with ICU delirium. And these range from analgesics, meperidine in particular, opioids. We'll come back to benzodiazepines because they've received a lot of the attention lately, but there are certainly many others. I want to point out that anticholinergic medications of any kind are considered to be the drugs that cause delirium at the highest likelihood. And you can see that these include things like antidepressants, antipsychotics, antihistamines, antispasmodics, and so forth. And the effects of any one of these may not be that great, but certainly when they're added together can create a very high anticholinergic score, and that alone may be a considerable risk for delirium. So on this slide, I've shown the anticholinergic burden scale, which has been worked out, and you can see that the worst offenders, the scores of 3, the severe anticholinergic medications, are the antidepressants. There's a very long list of medications, and of course, medications like atropine itself and scopolamine. But even if you look at the left-hand side, where the score is milder, the score of 1, if you look at medications closely, you can see that some of them are extremely commonly applied in the ICU, from beta blockers, antihypertensive medications, analgesics, anti-anxiety medications, digoxin, fentanyl, drugs that we use so routinely in the ICU, metoprolol, that if you begin to add them up, the anticholinergic score can be really quite high. And it's for this reason that polypharmacy of any kind is discouraged, but certainly polypharmacy of medications that have any anticholinergic score has to be considered relevant and potentially dangerous for patients in terms of their risk for developing delirium. I also would like to point out that medication withdrawal has been associated with delirium, and it's not just the alcohol-related withdrawal that goes along with, for example, delirium tremens, but withdrawal of medications like barbiturates, sedatives, hypnotics, even nicotine can lead to the full syndrome of delirium if tested for. So again, nicotine, opioids, and SSRIs have to be either discontinued slowly, or at least patients have to be monitored for the possibility that their syndrome may be related to it. One of the most important things I'd like to highlight during this talk is that delirium, as a syndrome, has a very long differential diagnosis. It's not sufficient to accept that somebody who is diagnosed with delirium just has delirium because they're critically ill. There's a very important differential diagnosis, and I've given you the acronym IWatch-DEATH to consider on every patient who develops any episode of delirium. And these include infections, withdrawal, as we just spoke about, metabolic dysregulation, trauma, of course, really any central nervous system pathology from strokes to infections can cause the syndrome of delirium. Hypoxia, although we certainly monitor that continuously in the ICUs, and then deficiencies, endocrinopathies, vascular catastrophes, toxins, and heavy metals. Now, many of these things are rare, but some of these things, such as thyrotoxicosis, for example, or myxedema, have very specific and very treatable therapies, very specific therapies, and are very treatable problems, but unless you're aware that that's what's causing the delirium in the first place, you would not know how to treat it. The point is that this differential diagnosis must be considered on every patient before adequate treatment really can be offered. And we talked about why does it happen to so many people. I think, I'm not going to pretend to understand the full physiology of delirium and why it occurs. I think this slide is an excellent summary of some of the pathways thought to be involved. There's an aging pathway, neuroinflammatory pathway, oxidative stress, a diurnal pathway where melatonin dysregulation is thought to be relevant. And I think it's fairly easy to see that each patient may bring some or even just one of these to their critical illness with them. An older person perhaps who develops an inflammatory condition or a condition that increases oxidative stress, and then they are admitted to the intensive care unit where perhaps sleep is disturbed, and that's been very well worked out. And when these things are added together, they certainly increase the likelihood that any individual patient will develop an episode of delirium. So it's sufficient to understand that there are different pathways for people to reach that final common pathway of delirium. And I probably won't say anything further on pathophysiology. Let's talk instead about the consequences of delirium because they're really quite dire if you think about it. There are short-term consequences, that is, those that occur while the patient is still hospitalized. And these include things like longer time on mechanical ventilation, longer lengths of stay in the intensive care unit and the hospital, and death. And then there are the longer-term consequences, which we'll come to momentarily. So this was an excellent summary of the literature published in the British Medical Journal in 2015 that really looked at some of the better literature on these related topics. And so first they looked at the impact of delirium on mechanical ventilation. In other words, does an episode of delirium lead to longer time on mechanical ventilation? And this forest plot really suggests that that is the case, that patients with delirium in aggregate, if you look at the sum of the available best literature, you can see that this final total triangle here is to the right of this, the line which suggests that in summary, the literature suggests that delirium does lead to longer length of stay on mechanical support, and they came up with a number of just under 2 days longer, which is actually really quite impressively long. Almost 2 full extra days on mechanical ventilation for patients who have suffered any episode of delirium. It doesn't quantify how many days any episode of delirium led to longer time on mechanical ventilation. And this has been borne out in several studies that were included. This study again, you can see here on the right side of the screen that for patients who have any episode of delirium, you can see in the lower line here, that their successful extubation is delayed for any given number of days until almost the very end after 2 months where it equalizes. But if you have no episode of delirium, then the vast majority, 95%, are successfully extubated within that 10-day period. Similarly, in a study in the Korean Peninsula, they found the same thing. This graph looks very similar to that last one, with successful extubations being done more quickly and earlier in patients who do not experience delirium. You can see that extubations were more likely to occur in the confusion assessment negative, delirium negative population, 81.5% versus 69%. Extubation failures were more common in those who had been diagnosed with delirium. And reintubation rates were actually higher in the delirium population as well. Tracheostomies were more common in patients who had an episode of delirium. And of course, as we talked about, lengths of stay longer in those delirious. So really, the consequences are really quite impressive in terms of mechanical ventilation. Similarly, when the same systematic review and meta-analysis looked at the effects of delirium on mortality in the hospital, they found the same conclusion, that delirium was associated in the aggregate of the literature was associated with a risk of higher hospital mortality. So that's the short-term effects of having delirium. That's having any episode of delirium while in the intensive care unit. Let's talk then about the longer-term consequences. Well, this study came out from the group at Vanderbilt in the Journal of the American Medical Association in 2004, and I think really was one of the seminal studies that brought to the critical care community just how important this diagnosis is. So it highlighted that at 6 months, which was their endpoint, that having any episode of delirium while in the hospital predicted death and disability at 6 months. So really a wake-up call, I think, at least to the critical care community, that this was a very important diagnosis to pay attention to. But what about survivorship? What about those people who survive their intensive care unit time, survive their hospitalization, go home, and maybe fit into the other category, people who survive beyond that 6 months? What does survivorship actually look like? And this is really something that's only gained attention more recently, the longer-term consequences to patients who survive an episode of delirium in the hospital. Well, there's a relatively new diagnosis of post-intensive care syndrome, and that's diagnosed as defined as a new or worsening impairment in cognition, mental health, and physical function after a critical illness. Now, why I mention that is because one of the risk factors is, as you can see here on the right side of the screen, any episode of delirium experienced in the intensive care unit and is a risk factor for this lasting consequence of post-intensive care syndrome. Other risk factors include a longer length of stay, older age, sedation, and again, these are the sedatives and anticholinergic drugs we just talked about as a risk factor for delirium. So there probably is a relationship between medications, delirium, and then the post-intensive care syndrome. And mechanical ventilation, similarly, longer length of stay on mechanical ventilation, also very high likelihood of delirium and this post-intensive care syndrome. And the common symptoms of this syndrome are critical illness, neuromyopathy, depression, general anxiety, post-traumatic stress, and cognitive impairment. So patients who survive their ICU time, if they've had delirium, are very much at risk for developing this post-intensive care syndrome, which is really only now being worked out in terms of what can be done for these patients. But again, I want to highlight that any episode of delirium experienced in the intensive care unit is a risk factor for developing these lasting consequences, which in some cases can be quite debilitating and can affect patients' productivity, quality of life, and ability to return to some normalcy. Post-ICU syndrome is common. 40 to 80% of patients at discharge will be cognitively impaired. At 3 to 12 months, many of them will have cognitive impairment that's comparable to somebody with traumatic brain injury. At 12 months, many patients will still report higher rates of anxiety, PTSD, depression, and functional impairments, in addition to many other symptoms from sexual impairment to inability to return to work and chronic pain and so forth. This was the study recently in the New England Journal that highlighted the cognitive impairment that can occur after patients had been hospitalized for either medical or surgical respiratory failure or shock. And again, this is not just a problem of older people, but it also occurred in patients younger than 50 years old. I did want to point out, though, on this slide that it's somewhat related to the days delirious, so that delirium is certainly a risk factor for the long-term cognitive impairment, and the duration of delirium is also a risk factor for worsening cognitive outcomes. So the longer the duration of delirium in the hospital, the worse the global cognitive score in this study. This was just one interesting study from a Danish group that has a post-ICU clinic, and what they found was that 64% of their patients referred to their clinic with post-ICU syndrome had been diagnosed with delirium, but 19 of the other 28 who were not diagnosed with delirium still had delusional memories, suggesting either they were undiagnosed and did have delirium, or perhaps just had subsyndromal delirium. But either way, it suggests that about 83% of the patients that were referred to this post-ICU clinic had some kind of acute brain dysfunction, very likely that was delirium, during their ICU stay. So it's a very, very high, important risk factor for the development of post-ICU syndrome with all its quality of life related outcomes. And that brings us to treatment. Treatment really, to this day, remains best if it's prevented. That is, if delirium doesn't occur in the first place, because I've tried to make the point that any episode of delirium really leads to the downstream effects that are seen and known now. So prevention is really still our best hope, not polypharmacy. That is, we can't make this problem go away by medications. In recent years, a more thoughtful and organized approach to sedation and analgesia has really led to what now has become a more appropriate standard of care with really good results showing a reduction in the incidence of delirium. This was a study from Washington where what they did was they looked at their practice in sort of a run-in period without a sedation protocol. And then they instituted a protocol to improve their use of analgesia and sedation to see whether it could have an effect on their outcomes. And in this red line, you can see that before they instituted their protocol, their sedation and analgesia reducing protocol, they had a higher incidence of delirium than after they instituted their protocol. And so that was a very successful result of a protocolized approach to sedation and analgesia, and it really has informed what we now consider to be the standard of care and is referred to sometimes as the ABCDE approach to sedation and analgesia. And that's the awakening and breathing protocol that we know gets people off mechanical ventilation quickest. This C is sometimes considered to be choice of sedative and a more thoughtful approach to sedation or sedation reduction. And then there's the delirium monitoring and early mobilization. When this ABCDE bundle is implemented, it has been proven to reduce the incidence of delirium, ventilator-free days, and outcomes overall. So you can see in terms of ventilator-free days, there was a significant reduction. In terms of delirium, it was a significant reduction once the bundle was applied. And this really now has become, I think, a standard of care. Analgous sedation of choice, according to the ICU liberation protocol, since C is the choice of sedative, so is really a fentanyl infusion. And you know that fentanyl itself is not a sedative at all. It's really an attempt to minimize the amount of mind-altering medications that we have to use. So the Society for Critical Care Medicine has put out their ICU liberation protocol, and if any infusion is considered necessary, they recommend fentanyl. Any routine use of benzodiazepine is discouraged by them and by the pain, agitation, and delirium guidelines that they endorse. If a continuous sedation is required, for whatever reason, then dexmedetomidine is thought to have advantages over the medications such as the benzodiazepines and even propofol, in part because it has been associated with a lower risk of developing delirium. Regardless of the choice of sedation, it's important that we avoid too much for too long. Those patients who are on sedation infusions still are advised to have daily interruption of sedation unless there's an obvious contraindication to doing so. And that, again, is to minimize that problem of too much for too long, where the pharmacokinetics change and the medications last in the system and affect patients' cognition for longer. And then, and this is important, there are non-pharmacologic strategies for helping people to deal with the stresses involved in intensive care unit care, and these include sleep promotion, music therapy, other techniques for relaxation. Early mobilization is certainly one of the keys to this now, and obviously incorporating families and assisted communication protocols to help people communicate and to try to minimize their need for medications. And there are others. I've just chosen to highlight a few. So the Pain, Agitation, and Delirium Guideline Care Bundle is just what the Society for Critical Care Medicine puts out. The most recent iteration of it was published in 2013, and they're working on another one, which hopefully will come out in the coming year or so. This is just to point out that, again, non-benzodiazepines are preferred unless patients have alcohol withdrawal, and in which case it remains the standard of care. And that for delirium, they recommend some assessment tool, such as the CAM ICU, but minimizing medication still is our best hope for avoiding delirium, but we still can expect to successfully treat agitation just to minimize the medication doses and certainly minimizing the number of medications necessary. And I can't stress enough that early mobilization is an important part of this. I want to conclude by a few words about sleep because there are some misconceptions about sleep and its relationship with sedation and how this may be relevant to the discussion we've just had. Sleep is an essential biological function that is circadian. It's continuous and consolidated in one period of time, that is that we sleep generally in one extended block of time rather than little naps throughout the day and night, and it's characterized by cycling sleep stages. None of those factors is true for sedation. It is neither essential circadian, it's not consolidated, and it's certainly not characterized by cycling sleep stages. In one recent systematic review, the 8 or so articles that looked at interventions to improve sleep and how they affected the incidence of delirium were summarized. And you can see that here that there was a fairly strong tendency to showing that those interventions aimed at improving sleep reduced the incidence of delirium. And this has been suspected for some time that helping people to sleep might help patients cognitively and might improve their chances of not developing delirium. Interestingly, most of these studies were unable to prove that sleep itself was improved, but delirium seemed to go down in incidence. And it's also important to point out that most of these studies did not use a pharmacologic approach to helping sleep. These were mostly protocolized, non-pharmacologic approaches to improving sleep, and yet they seem to affect the incidence of delirium in a very positive way. So the take-home messages are that delirium is very common, especially in older and sicker people. Some cases of delirium are iatrogenic, and therefore it's especially important for us to be mindful of how we administer medications, and particularly with regard to analgesic and sedative medications. Delirium is associated with longer lengths of stay, longer lengths of time on mechanical ventilation, and death in the short term, that is during their hospitalization, and death and the post-ICU syndrome in the long term. There is no treatment that is known to affect the course or outcomes once delirium has been diagnosed, so prevention remains the key. And really the standard of care, if followed, that is the ABCDE bundle, really has been shown to reduce the incidence of delirium and should be considered the standard of care. And with that, we'll go into just a couple of questions. Question number 1. A 56-year-old man with hypertension and diabetes is admitted for sepsis. He is intubated, sedated with a midazolam infusion, and treated with broad-spectrum antibiotics. On day 3, his cultures confirm that he has Legionella pneumonia, so his antibiotics are de-escalated. On day 7, he is hemodynamically stable, his midazolam infusion is stopped, he passes a spontaneous breathing trial. extubation is considered, but he is uncooperative and belligerent. Which of the following is true? A, he needs a head CT to rule out a stroke or a CNS abscess. B, his antibiotics were de-escalated too soon. C, he's most likely delirious from the lasting effects of midazolam, even though midazolam has a short half-life. Or D, you should tell his family that his mental status will be back to normal by the time he's discharged home. Well, the answer, I think the best answer is C, that he's most likely delirious from the lasting effects of midazolam, even though midazolam has a short half-life. In terms of A, it's not wrong to think about CNS pathology, particularly because I think one of the take-home points I especially wanted to stress is that there is an important differential diagnosis for delirium. So if this patient is delirium, it is right to think that he could have something like a CNS infection or a stroke or something. But more likely than not, because he was on a midazolam infusion, simply speaking, this would be much more statistically likely than a random CNS event occurring in somebody who had a Legionella pneumonia. So A is not necessarily wrong to think of, but certainly I think the more likely correct answer is C. I don't think it's true, as in B, that his antibiotics were de-escalated too soon. I think that we have to be good stewards of antibiotic use, and for somebody who has a confirmed infectious source, it's not just reasonable, but it's our obligation to de-escalate. So I think that's not the case, that he was de-escalated too soon. And in E, I think telling his family that their expectation is that he would be back to normal by the time he's discharged is really not reasonable now, knowing that patients who have suffered delirium often will leave the hospital with some of the lasting effects, specifically with regard to cognition and so forth. Question number 2. The patient in question number 1 is extubated, and then he's transferred to a rehabilitation facility for 2 weeks before returning home. He is able to return to his job as a supervisor at a clothing factory several weeks later. He presents for follow-up appointment with his primary care provider 2 months after discharge home. He tells you that he has memories of the nurses trying to kill him in the ICU and he's having trouble sleeping. Which of the following is true? A, it would not be surprising if he has cognitive problems that were not present prior to his admission. B, his delusional memories suggest he's having a psychotic episode and he should be rehospitalized. C, if he had been given more midazolam during his hospitalization, he would not have delusional memories and he'd be less likely to have post-traumatic stress syndrome. D, at this point, so far removed from his hospitalization, his sleep and memory problems must be something that newly developed after discharge. So which of the following is true? I think A is the most true, is probably the only true. It would not be surprising if he has cognitive problems that were not present prior to his admission. As we talked about, it's not uncommon at all for patients to have cognitive problems that they did not have prior to hospitalization on discharge and for sometimes many months subsequent to their hospitalization. In answer B, his delusional memories suggests he's having a psychotic episode is not true. His delusional memories may simply reflect that he had delirium while he was in the hospital. It turns out that these delusional memories can be extremely vivid, and that they can be remembered in some cases, we've heard patients say, even more vivid years later than normal memories. So they can be quite permanent in that sense and have absolutely no relevance to a psychotic episode. These are simply some of the lasting consequences of having had delirium for some patients. In C, if he'd been given more midazolam during hospitalization, in fact, he would have been more likely to have post-traumatic stress. It may seem counterintuitive, but benzodiazepine and sedative use actually seems to increase the chance of having had PTSD, not lessen it. And finally, so far removed from his hospitalization, sleep and memory problems are still, unfortunately, a consequence of having had delirium. There's no reason to suspect something new, although that's a possibility, I suppose, for some, but it's really almost certain that the person's delirium, perhaps due to the midazolam he received, will have led to him having difficulty sleeping that has been shown to be lasting, and certainly memory problems are part of that cognitive issue that sometimes lasts long beyond hospitalization, but still relates back to the delirium experience during their critical illness.